Good evening to our dear colleagues in the Philippine Obstetrical and Gynecological Society Foundation Incorporated. Indeed, let us all congratulate ourselves for our first historical hybrid annual convention and 74th anniversary celebration. In line with that, we are celebrating a wealth of knowledge from our various speakers, but tonight is special. Tonight, we will be graced upon by one of our most sought after colleagues here and abroad. Of course, our topic for this afternoon, and this evening I should say, is practical interventions in hyperglycemia and caloric energy deficiency during pregnancy. Let's get to know our special speaker. Dear colleagues, please give a virtual response, virtual applause to our speaker of the night, Dr. Richard Georges. Hello, Dr. Jinky.
Hello and good evening to our Madam President, Dr. Cristia Santiago Padulina, and to all our viewers. All right, before we get into our discussions tonight, let's first explore the landscape of maternal health in the world, specifically on gestational diabetes, and zoom into the numbers that we are dealing with in our region. Let us turn our attention to this primer video.
Around the world, an estimated 425 million adults are living with diabetes. This includes gestational diabetes mellitus, or GDM, a type of diabetes affecting pregnant women. In Southeast Asia, 1 in 4 pregnancies are affected by GDM. Based on known GDM risk factors, 100% of Filipina pregnant women on the basis of ethnicity are considered at risk of developing GDM. GDM is a serious maternal and fetal burden. What action can we take now to prevent moms from developing it? Today, our experts will delve more into gestational diabetes mellitus, specifically on practical interventions in hyperglycemia and caloric energy deficiency during pregnancy.
What we saw is an alarming conditions in terms of the numbers and facts about the serious burden of gestational diabetes in our country, in Southeast Asia, as well as in the world. Let's dive in a deeper to this issue as we move forward with tonight's discussion.
Indeed, diabetes mellitus has affected more than 425 million of adults worldwide. Definitely, it is a cause of concern. Gestational diabetes mellitus is considered as a public health burden, having an incidence of less than 1%, but affecting 28% from 173 countries. Let's take a look at the Asian incidence. Please take note that in Southeast Asia, we have the highest prevalence of hyperglycemia in pregnancy, and a quarter of it is affected as compared to 1/7 in the global prevalence. Definitely, in the Southern Eastern Asia, our incidence, including that of the Philippines, is about 10.07%. It is therefore but prudent for us to look into the pathophysiology of diabetes mellitus in pregnancy so that we will be able to address the issue right away. Dr. Jinky, please.
Yes, thank you, Dr. Cristia. The basic pathophysiology of diabetes mellitus in pregnancy, or gestational DM, or otherwise known as hyperglycemia in pregnancy, is primarily because of the carbohydrates of foods that we are eating. These sweets and starchy foods are broken down by the body into glucose and released into the blood. When the glucose level in the blood increase the body, releasing an increased amount of insulin coming from the pancreatic beta cells. This insulin helps move the glucose out of the blood and into the body cell where it can be used for energy and fuel, especially for the developing embryo and the fetus. Okay, so here is a slide which is quite familiar as far as the explanation and understanding of the basic pathophysiology of diabetes mellitus in pregnancy. Now, there are several physiological adaptation and changes that usually occurs during pregnancy, and one of these is the metabolic adaptation. Now, as you could see in this slide, there is compensatory hypertrophy and hyperplasia of the pancreatic beta cells, which is quite an important response during pregnancy because there is peripheral insulin sensitivity decrease, or there is fail of this insulin sensitivity, resulting into increase in the concentration of glucose in the bloodstream. Thus, again, we have to take note that the pancreatic cells adapt and responds to this physiological adaptation by means of hypertrophy and hyperplasia of the pancreatic beta cell. Okay, so what happens in cases of diabetes mellitus is that the pancreatic beta cells fails to respond properly. Okay, so what happens is that there is inadequate hypertrophy as well as hyperplasia of these cells, and with the background of decreasing or falling of the insulin sensitivity, there is marked glucose that stays in the bloodstream, resulting into hyperglycemia. Now, one of the considerations in terms of giving lectures as far as the basic pathophysiology of diabetes in pregnancy, it's not only the metabolic adaptation, but at the molecular level, okay, there is faulty signal in terms of the response of the receptors for insulin, as well as the channels in which these channels are considered to be the one responsible for the influx of glucose from the blood inside of the cell. The development of hyperglycemia in a pregnancy or gestational diabetes mellitus is usually secondary to pancreatic beta cell dysfunction at a background of insulin resistance. The insulin secreted from the beta cells binds to the insulin receptors and will in turn signals the glucose transporter 4 to open and allow the entry of glucose inside the cells for consumption. Now, here are the basic explanation as far as the signaling of these insulin receptors is concerned. First, insulin resistance occurs when the cells are no longer adequately responds to insulin. Okay? So what happens is that at the molecular level, insulin resistance is usually a failure of insulin signaling, resulting in inadequate plasma translocation of glucose transporter 4, or your GLUT4, which is believed to be the primary transporter that is responsible for breaking glucose into the cells for energy consumption. Now, this is a very important slide that I think everybody should understand. The basic pathophysiology of gestational diabetes mellitus and diabetes type 2 is identical for most part. During pregnancy, the carbohydrate metabolism changes. In the first trimester, there is increased estrogen and progesterone coming primarily from the developing placenta. Now, aside from this estrogen and progesterone, we have also secretion and productions of human placental lactogen, leptin, cortisol, and even placental growth hormones. The levels, no, of these hormones are associated with a decrease in the fasting blood sugar until 12 weeks age of gestation. Now, from the second trimester, there is a risk of peripheral insulin resistance, no, brought about by these anti-insulin signals from the placenta or coming primarily from the hormones which is secreted by the placenta. This will trigger a rise in the fasting and postprandial glucose, leading to the transplacental transfer of glucose into the bloodstream of the fetus. Lowered transfer of maternal amino acid as well, and increased carbohydrate mobilization to supply the fetal demands usually follow this type of consequences. Maternal carbohydrates metabolism is diverted into fat and it's increased insulin resistance. That's why, aside from the hormonal changes that occurs during normal pregnancy, cytokines and adipokines may release from the adipose tissue into the placenta and would further increase the concentration of glucose into the bloodstream. Now, aside from the signaling of these insulin receptors to open the transporters in order for glucose to come in inside of the cells, the rate of insulin stimulated glucose uptake is usually reduced by 54% in cases of gestational diabetes mellitus when compared with normal pregnancy. Okay, so that is quite high, 54%. While insulin receptors is abundant, okay, so what happens, it is usually unaffected. And this is usually attributed to reduce in certain amino acids. No, particularly you have your tyrosine or an increase in the serine and threonine phosphorylation of the insulin receptors dampens no the insulin signaling. Okay, so next slide. Next slide. Now, in addition to altered expression or phosphorylation of downstream regulators of insulin, we have three important factors that we have to take note. And what are these? We have first the insulin receptor substrate, which is usually compromised if there is an increase in the insulin resistance. Second is an enzyme, which is known as the phosphatidyl inositol 3 kinase. Kindly remember that. And lastly, you have the transporter or the pore, which is important in terms of delivering glucose inside of the cell. And this is the glucose transporter 4. Now, when we define diabetes in pregnancy, it is usually carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. And here we have the protocol for the evaluation of diabetes in pregnant Filipino women. What is being advocated by the Philippine Obstetrical and Gynecological Society is to screen all Filipino pregnant patients during the first prenatal visit, preferably on the first trimester of pregnancy, by requesting the fasting blood sugar. Now, if the fasting blood sugar is less than 92 milligrams per deciliter, then it is considered to be normal. But you have to take consideration of the risk factors for GDM or hyperglycemia in pregnancy in all pregnant patients on their first prenatal screening if this turns out to be normal. If there is or are presence of other risk factors, then you have to proceed in doing the 75 grams oral glucose tolerance test. Okay? Now, there are some colleagues asking, why is it that the hemoglobin A1C and the random blood sugar is no longer being requested? Okay? Now, this is based primarily on the recommendations of the International Association of Diabetic Pregnant Women Study Group. Now, if, for example, you failed to screen your patient on the first trimester of pregnancy, on the second trimester between 24 to 28 weeks age of gestation, you could request for the second screening of 75 grams oral glucose tolerance test. Or if your first screening, the fasting blood sugar in the first prenatal visit turns out to be normal and there is no risk factor, then you have to proceed on the second trimester screening, requesting for the 75 grams oral glucose tolerance test on the same age of gestation, which is 24 to 28 weeks age of gestation. Now, if your pregnant patients is normal, no, has a value of less than 92 milligrams per deciliter for fasting, first hour is less than 180 milligrams per deciliter, and the third hour or the second hour is 153 milligrams per deciliter, then your patient is considered to be normal. Now, if, for example, your patient failed, okay, to have a screening on the second trimester, you could still screen at the 32 weeks age of gestation or third trimester of pregnancy, requesting 75 grams oral glucose tolerance test. But if, for example, you have a normal value of 75 grams OGTT on the 24 to 28, and suddenly your patient, after the test, usually exhibit hyperglycemia, okay? Or there are symptoms and signs of maternal as well as fetal hyperglycemia, then you have to request the 75 grams OGTT right away, okay? So this is what we follow as far as the screening of GDM or hyperglycemia in pregnancy. Try to remember the first screening on the first trimester. The second would be on the 24 to 28 weeks age of gestation. And the last is at 32 weeks age of gestation.
The protocol is quite important for screening out gestational diabetes or hyperglycemia in pregnancy. Ours is the only specialty that deals with two patients. And showcasing this, we need to prevent maternal, fetal, and neonatal complications. Please take note that hand in hand, one could be able to appreciate the presence of preeclampsia. Big babies would redound to lacerations in the maternal perineum, and of course, a heightened incidence of operative deliveries. Moving forward, one would be able to see that one would have either growth abnormalities or even intrauterine fetal demise. And neonatal complications would be most dreaded by our pediatrician counterparts. Please take note, if we take a look at the next slide, we would be able to see the fetal systems affected by maternal diabetes mellitus. It affects almost every system in the body of our patients. Please take note, our pediatric or fetal systems affected would include the cardiovascular system, neurologic inclusive of holoprosencephaly and NTDs, gastrointestinal would be inclusive of duodenal atresia, cleft lip, and cleft palate, and of course, we could also have cases of hemivertebra, and in the genitourinary tract, ureteral duplication, renal agenesis, and hydronephrosis. I am sure our colleagues listening right now would like to know, how do we medically manage the medical management of nutrition, I should say, for diabetes mellitus?
Okay. So as far as the medical nutritional management for hyperglycemia in pregnancy is concerned, we have to take consideration of the pre-pregnancy body mass index of our patient. It is quite an important factor that we have to include this BMI on the first prenatal visit, preferably on the first trimester of pregnancy, as part of her vital signs. Okay? So we have underweight, in which the BMI is less than 18.5. Normal is 18.5 to 24.9. Overweight is 25 to 29, and obese has a BMI of greater than 30. I would like to emphasize the importance of weighing our patient every prenatal contact and prenatal visit, because we have here the recommended total gain or total weight gain in pounds and in kilograms based on the BMI of our patient. Next slide. Now, as far as computing for the medical nutritional therapy, we have to take consideration of the height of our patient, and we compute for the ideal body weight and compute the kilocalorie which is required, okay, for your pregnant patients. This is usually individualized. Now, as far as the caloric distribution of medical nutritional management therapy is concerned, we have the highest percentage, which is the carbohydrates, which is followed by the fats, 20 to 30%, and we have proteins, 10 to 15%. Please try to remember again that usually on the second and third trimester of pregnancy, we have to add another 300 kilocalorie per day, okay, as an energy requirement, no, for the fetus and of course for the mother as well. Now, let us discuss, no, myoinositol for hyperglycemia in pregnancy, and I think this is one of the practical interventions, no, which is quite promising in terms of decreasing the chances or the possibility of having hyperglycemia in pregnancy.
Yes,
Now,
Jinky, kindly teach us. Aside from the medical nutrition of hyperglycemia in pregnancy, we would like to know whether this one is also safe. Remember, we have two patients.
yes, Doctora, this is quite safe, and we have here the slides that would give us an idea of what are the functions of this myoinositol. Basically, as I discussed the pathophysiology of hyperglycemia in pregnancy, there is a decrease or there is a fall in the insulin sensitivity, peripheral insulin sensitivity. Now, myoinositol increases, no, this insulin sensitivity, and this is one of the factors that is considered. Why is it that myoinositol has something to do with the uh, glucose regulation during pregnancy? Next slide. So where can myoinositol can be found? Okay, so we have here the most common sources of myoinositol. Wheat bread has the highest percentage or milligrams, no, of myoinositol content, which is followed by grapefruits. We have also oranges, okay, walnuts. So this myoinositol is basically seen in all food types. Now, what is the mechanism of actions of myoinositol as far as regulating the blood glucose and the possible reduction of gestational diabetes mellitus? So let us discuss briefly the mechanism of action of myo-inositol in glucose regulation, and the possible reduction of hyperglycemia in pregnancy. So on this slide, it was previously discussed, no, regarding the three basic pathophysiology in terms of the possible recurrence or the possible insulin resistance that happens in cases of hyperglycemia in pregnancy. We have altered expression and or phosphorylation of downstream regulation insulin signaling, which includes, first, we have the insulin receptor substrate. Second, we have the phosphoinositol 3 kinase and the transporter, which is the glucose transporter 4. This has been described as one of the basic causes of gestational diabetes mellitus as far as insulin resistance is concerned, and many of these molecular changes usually persist beyond pregnancy. That's why we have cases of patients who develop or entitled not to develop diabetes mellitus type 2 after pregnancy. So we have here the different mechanism as far as the action of myo-inositol in regulating glucose and possible reduction on the gestational diabetes mellitus. We have here the first pathway, which is quite technical. Then second, we have the second pathway, which is more technical, but I would like to discuss this briefly with my next slide. So this is an important slide in which I will be discussing the basic function of myo-inositol in terms of its glucose regulation. We already mentioned that there is insulin receptor signaling, which is quite an important factor for insulin resistance. Now, myo-inositol is present on the cell membranes, okay? And this is an important factor in which this would increase the number of insulin substrate receptors. If there is an increase in the insulin substrate receptors, there will be more binding of insulin to the insulin receptors, and this will further stimulate the glucose transporter 4 to open and, of course, accept this glucose, which is outside of the cell, going inside of the cell, okay? Now, as I mentioned earlier, most of this glucose, if it is not being used, are usually converted into glycogen. And some of this glucose enters aerobic glycolysis, no, in which we have the byproduct are pyruvate, and we have ATPs now being produced on this glycolysis. And some of this will go and enter the fatty acid cycle.
Jinky, are you sure this is quite safe for pregnant patients?
Yes, Doctora. Actually, there is no adverse events with 4 grams per day of myo-inositol supplementation among pregnant women who were obese, at risk for GDM, and with a family history of type 2 diabetes, or those who are diagnosed with polycystic ovarian syndrome. So there is a study in Mexico regarding the effectivity of myo-inositol during pregnancy. And the objective of this study is to compare the incidence of gestational diabetes mellitus in women at high risk of developing GDM supplemented with myo-inositol plus probiotics versus women with greater prenatal without supplementation. And the conclusion is that for those pregnant patients with supplementation from 12 to 14 weeks age of gestation up until the second trimester, which is roughly around 24 to 28 weeks, those who were given myo-inositol plus probiotics reduces the incidence of gestational diabetes or hyperglycemia in pregnancy in Mexican women, but randomized clinical trials are required to confirm these findings. Next slide. Now, as far as the management for diabetes is concerned, we just don't concentrate on the medical nutritional as well as giving supplementations to our pregnant patients. We have to advise that one of the key important management for diabetes is physical activity. Okay, and we have to take consideration of some of the contraindications. Now, why is physical activity or exercise may not be suited no for other pregnant patients because of certain medical conditions or complications brought about by pregnancy. Next, it is an important aspect in the management of diabetes that we have to follow up our patient during the postpartum period. So it does not end after the delivery of the product of conception. Again, we have to reclassify our patients, and this is usually done 4 to 12 weeks postpartum of or after the delivery of the product of conception. What we usually request is the fasting blood sugar and of course the 75 grams oral glucose tolerance test. Based on the cutoff after the delivery of the product of conception or during postpartum, we could reclassify our patient if our patient has only GDM or if our patient has already type 2 diabetes mellitus or diabetes itself, or our patient has an impaired glucose tolerance.
Thank you, Dr. Jinky, for discussing comprehensively hyperglycemia in pregnancy. Let's now go to the other extreme end of this spectrum of problem. Let's now go to the burden of undernutrition. So please take note that the Philippines has its own burden in terms of undernutrition and micronutrient deficiency. This appears in four kinds of scenarios. It's either an intrauterine growth restriction, low birth weight with protein energy malnutrition. It could also be chronic energy deficiency in women and micronutrient deficiencies. We see this in all aspects, be it in public health or in private practice. Next, please. Please take note that this global burden of maternal and child undernutrition, including that of micronutrient deficiency, ends with stunting. And definitely, this is not an exclusive to Africa. We have our own share here in Asia, here in Philippines. Moving forward, please take note that the maternal undernutrition is most prevalent in Southeast Asia and ranging from 10 to 40%. Maternal malnutrition is also responsible for IUGR. In so doing, please take note as we move forward in the discussion, we are able to see the burden of undernutrition. In the first 1,000 days, the obstetrician takes care of the first 270 days during gestation. It is crucial at this point in time that we utilize this as a window of opportunity to ensure that we are able to address this issue of undernutrition. Next. This maternal undernutrition or chronic energy deficiency could come in terms of women presenting with BMI of less than 18.50. So lesson learned, in all our patients, it is important to include in our prenatal armamentarium to do BMI evaluation. So, maternal morbidity and mortality is increased with this disease problem. We have the whole range of anemia, infection, poor pregnancy outcome, inclusive of IUGR, underdevelopment of some organs, and sad to say, even brain damage. And
Yes,
so,
Doctora.
let's now explore with Dr. Jinky the health risk associated with micronutrient deficiency.
Okay, so after discussing the end part of the spectrum, regarding diabetes mellitus, obesity, and overweight. These are the health risks associated with certain micronutrient deficiency. We have poorer health, lower socioeconomic status, decrease in the work capacity and earning potentials, and this will be further discussed on my succeeding slides. And for those with multiple micronutrient deficiency, only one form of undernutrition due to inadequate intakes combined with impaired absorption due to the disease, inflammation, and we have infection. Now, let me discuss the cycle or the circle that encompasses undernutrition. Nutrition challenges continues throughout the life cycle. So poor nutrition often starts in utero and extends particularly for girls and women well into adolescence and adult life. It also spans generation. Undernutrition that occurs during childhood, adolescence, and pregnancy has an additive negative impact on the birth rate of infants. Low birth weight infants who have suffered intrauterine growth restriction as fetus are born undernutrition or undernourished and are at far higher risk of dying in neonatal period or later infancy. If they survive, they are unlikely to significantly catch up on this lost growth later and are more likely to experience a variety of developmental deficit. A low birth weight infant is thus more likely to be underweight or stunted in early life, and the consequences of being born undernourished extends up until adulthood. Now, this is a very interesting phenotype theory as far as the development of metabolic diseases are concerned. The thrifty phenotype hypothesis proposes that the epidemiologically associations between the poor fetal and infant growth and the subsequent development of type 2 diabetes and the metabolic syndrome results from the effect of poor nutrition in early life, which produces permanent changes in glucose insulin metabolism. Now, these changes include reduced capacity for insulin secretion and insulin resistance, which combines with the effect of obesity, aging, and physical inactivity. And the most important factor is determining type 2 diabetes sooner or later in life. Okay? So, diabetes is not only seen during pregnancy, but it is quite an important aspect as far as nutrition of these women are concerned. Okay, so let us discuss further the burden of maternal undernutrition. When we say intrauterine growth restriction, there is low birth weight. For those who are stunted, you have a low height for age. And for wasting, we have low weight for height, and micronutrient deficiency are usually less visible type of deficiency. So I would like our audience to be familiarized with IUGR, stunting, wasting, and as well as micronutrient deficiency. Dr. Christia, can you please tell us what are the maternal risk factors or health risk factors that are considered to be a burden for those women who are undernourished or who are suffering from chronic energy deficient?
Yes, Dr. Jinky, indeed, it has a lot of repercussions taking a look at this maternal health risk. Take note that if we have iron deficiency anemia, this is usually associated with a severe degree of endocrine and immune system deficient or uh, there is a endocrine and immune system deficiency. That is why it's quite important for us to look into also the vitamin A deficiency, which is associated, of course, with night blindness. And to further showcase, we also have vitamin B6 and vitamin B12 deficiency that is associated. Take note, placenta abruptio, stillbirth, preterm deliveries, and preeclampsia. And we also have vitamin K deficiency associated with nasal hypoplasia. Moving forward, we still have other maternal health risk factors that would include iodine deficiency, which in the first trimester would have repercussions in terms of goiter, impaired mental health function, hypothyroidism, and cretinism. Take note also that if we have zinc deficiency, this is responsible for PROM, increased risk of assisted vaginal delivery, and prolonged phase of protracted second stage of labor. Sad to say, even the vitamin D deficiency increases the risk of GDM and preeclampsia. I'm sure it also has fetal risk, health risk. Correct,
Yes,
Dr. Jinky?
yes, Dr. Padolina. We have here the list of the possible complications or fetal neonatal health risks, no, for those with micronutrient deficiencies. Folate deficiency is quite popular, and everybody knows this. That one of the detrimental effect of folic acid deficiency is the development of neural tube defects. Okay, and it is also associated with the possible development of low birth weight infants, preterm delivery, fetal growth restrictions, and even megaloblastic anemia. Now, it is quite an important micronutrient also for the possible okay, prevention of certain neonatal infections, especially in the first 2 years of life. Now, as far as iron deficiency is concerned, this is highly attributed in cases of preterm birth, low birth weight infants, and lower infant Apgar score during birth, especially the first and the 5 minutes of life. As well as maternal vitamin D deficiency is associated with congenital rickets and osteopenia or even craniotabes. Okay? So, other fetal risk factors associated with iodine deficiencies, the development of congenital goiter and hearing impairment. And everybody's not familiar with this, but if you have severe zinc deficiency, this may eventually precipitate into a spontaneous abortion or congenital malformation, plus the possibility of low birth weight, intrauterine growth restrictions, and preterm deliveries.
Thank you, Dr. Jinky, for sharing your valuable information and practical intervention of both hyperglycemia in pregnancy and undernutrition. Definitely, you have opened the eyes of our colleagues present in this webinar, not to the threat of gestational diabetes mellitus, not only in the Philippines, but of course, worldwide. With that, I think we still have time to address some questions in the chat box. Let me check. Dr. Jinky, in your practice, what is your preferred method of screening for gestational diabetes mellitus?
Okay, so it was pointed that the recommendation nowadays by the Philippine Obstetrical and Gynecological Society, which I also follow, is to screen during the first prenatal visit, requesting for a fasting blood sugar.
Okay, how about giving us practical tips on what is your preferred treatment and intervention for hyperglycemia in pregnancy?
Yes, no, especially for those who were diagnosed with gestational diabetes mellitus, I always teach my residents to compute for the caloric requirements for all cases diagnosed with GDM. Okay, so the first and the foremost is to engage with medical nutritional management, and I would also advise my patient personally to strictly follow know what is being prescribed by the dietitian in terms of its food exchange. Okay, and I usually monitor after 2 weeks of MNT so that I could see or know if the nutrition itself, no, or the diet itself is responding positively to our patients.
Okay. By the way, Jinky, do you have special maternal milk formulations that are recommended for gestational diabetes mellitus?
What is being emphasized in our lecture is that we have to give an extra 300 kilocalorie of energy, especially in the second and third trimester of pregnancy. And most of this milk preparation comes into 115 kilocalorie per serving. So we usually advise them of at least 2 serving of these milk formulas. And usually milk formula should be should contain less sucrose, okay, and it contains all of the micronutrients and macronutrients, which is necessary for pregnant patients. I just want to emphasize this, Doctora. Aside from the energy, okay, remember that when we prescribe multivitamins, we prescribe the micronutrients, okay? But remember that we also need to give macromolecules to our pregnant patients, and this can only be properly supplied by giving milk formulas during pregnancy.
Correct. Maternal milks for both micro and macronutrients. Okay. There's one last question here, I think. How early in the pregnancy journey should we be screening for GDM?
How early? As early as the first prenatal visit, preferably on the first trimester, we screen these patients for gestational diabetes mellitus. But as I mentioned on my lecture, usually the effect of these placental hormones, the estrogen and progesterone, are usually seen up until 12 weeks age of gestation. That's why usually on the latter part of the first trimester, I think that would be the best time to screen for GDM. Okay, because aside from the estrogen, progesterone, we have other hormones secreted and produced by the placenta, which usually influence the metabolism of glucose during pregnancy.
Okay, that's about it. There's still a lot of questions, Dr. Jinky. You know that our colleagues really prioritizes GDM, and therefore it's anticipated that we have a lot of questions, but we do not have time to address all of them. So may I now request Dr. Jinky to give his parting message and closing remarks to address our colleagues who are present here right now.
Yes, again, thank you so much for inviting me to speak regarding diabetes and malnutrition. Together, of course, it is my privilege to be with our POGS President 2020, Dr. Cristia Padolina. Okay, so these are my thoughts, and I would like to share this to our audience. The complications of gestational diabetes or hyperglycemia in pregnancy are usually manageable and are preventable. Now, the key to prevention is carefully control the blood sugar levels just as soon as the diagnosis of diabetes is made. And the decline of resources, both for maternal and child health care, could easily manifest characterized by drastic decline in antenatal, neonatal, and essential maternal, infant, and child health care services, especially during this pandemic, okay? So most of our pregnant patients are afraid to go to the hospitals or have their prenatal checkup with their respective attending physician. Nutrition plays a major role in maternal and child health and it is widely recognized that optimum nutrition is the foundation in boosting health and immunity during pregnancy, even in times of pandemic.
Thank you so much, Dr. Jinky. As always, full of knowledge, very impactful lecture, showcasing your expertise on the subject matter. I myself would also like to share a bit of insights insofar as the discussion tonight is concerned. As obstetrician gynecologists, pandemic or not, GDM is a priority. Hyperglycemia in pregnancy is a public health issue, and so is undernutrition in pregnancy. Definitely, we should learn from each other, share experiences so that we are able to deal with it fair and square. Right now, even during pandemic, as guided by PSMFM, we should ensure that we provide the best care to our patients. And definitely, that is the way to go for all of us. So, on behalf of Dr. Jinky Georges, this has been your moderator for this evening, Dr. Cristia Espadolina. We hope that our virtual gathering finds you well, and wherever you are viewing us, thank you for attending virtually this evening. Again, virtual, applause to Dr. Jinky. Stay safe, stay healthy, and enjoy the rest of the night. Thank you so much.
Bukas pagising mo, bago na ang mundo. Bukas big boy ka na, pwede bang wag muna? Bukas na di mapigilan, di na lang sabayan. Bawat bukas ay bago, malaki man o maliit ito. Bukas lalaban o may matutuklasan o may biyaya na aalagaan. Bukas ang alam mo, di na totoo. Bukas kaya na niya, kahit na mag-isa. Bukas na pinagdasal mo pa ay narito na. Bawat bukas ay bago, malaki man o maliit ito. Bukas lalaban o may matutuklasan o may biyaya aalagaan. Basta't tandaan mo sa bawat bukas, nariyan ako.
She already said that I was predisposed to gestational diabetes. That's why from day one, when she found out that I was pregnant, I was already advised to take a diet as if I was diabetic. So I'm Sasha Timones. I'm 42 years old. I'm married with 2 kids, both boys, 7 and 9 years old, and very happy. It's not even the worry of when I had GDM, it's knowing what the worst case of GDM. Because my doctor was very clear about the bad effects. And it's, to be honest, it's very effective because it made me strict to it made me very disciplined in terms of my intake from day one. And I followed her to the letter as far as I'm concerned, because we had both one objective, the health of my baby and my health as well. The fear is always Okay, until you have your baby, and maybe until you die and you see your child married off and you see your grandkids, your fear is always that you lose your child. So, and that starts when you're still carrying them. So that's the worst case fear for me, that I might be doing something that could impact my child, and worst case, it will cause me to lose my baby. During the time I had GDM, I followed my doctor's advice to the letter. And I mean, to the letter. I followed my OB's advice to the letter. It's not convenient for you, but your baby will be fine. Diba? I guess the complication you will have there would be, how do you do that to the letter? Right? Lahat susundan mo. So yun yung, that's the difficulty there, because you will, it's very difficult to find food to eat. There's a lot of things that the world is not made for, but you have to figure out for yourself. And that's very stressful. Buntis ka na nga, hindi ka na nga makalakad, ng sakit na nga ng likod mo. Iisipin mo pa, oh my God, pati ba to? Diba? So they started off, of course, being understanding. And then, supportive. So, in doing, and what I mean by supportive, yun nga, na talagang they took into consideration what I can and cannot eat. Your nutrition matters a lot on how you will manage your GDM. And even how your GDM can escalate. You really have to look at what you eat. You have to plan what you eat. But you also have to think about, and for me, I had to think about everything that I had to take into consideration, from the nutrients to the amount of calories per day that I had to take into consideration, even variety of food. I trust my OB explicitly. She is, as far as I'm concerned, the lifeline of my baby and my lifeline. As far as I'm concerned, if my OB is not worried, I am not worried. If my OB says this, I will follow her, because we have a common goal, which is she wants to make sure that after my pregnancy, in both of my pregnancies, that I would have a healthy baby, and that I would live, of course, throughout my entire pregnancy, right? When I see them play, when they tell me, I love you, mommy, that's nothing can replace it. To my OB and to all the OBs, I'd like to tell all of you, thank you very much for the service that you are doing and have done. Without you doing what you do, without the care that you do, the genuine concern that you have given us mothers, to be honest, none of us would probably have families right now, or happy families, or even be, healthy right now. I would like to thank all of you. I cannot tell you what a great calling and service you have done to all of us, to people like me who've had very complicated pregnancies from the very beginning, to what you have done to me, to my family, the joy that you have brought into our lives, and essentially for making sure that, at the end of the day, that I could be a mother. From the bottom of my heart, from the bottom of my family's heart, thank you so much. And I hope you are all keeping safe, and I hope that you will never, ever, ever get tired of what you do.
Good evening to all of you, our dear doctors, and congratulations to the Philippine Obstetrical and Gynecological Society for having their first hybrid annual convention and 74th anniversary celebration. On behalf of Wyant Nutrition, thank you for allowing us to be part of such a momentous occasion in the history of POS. It is a privilege to be with you tonight, as well to celebrate a milestone for our maternals line. We are excited to introduce to you two new innovations, which are proactive nutritional solutions that will help women in their pregnancy journey. For over 100 years now, we at Wyatt Nutrition have been serving Filipino families and nourishing healthier tomorrows. Tonight, we are pleased to present to you these new offerings from the brands that encourages Filipino mothers to choose nutrition that's both pro-mama and pro-baby. Doctors, it is with great pride that we bring to you the new and improved Pro-Mama and Pro-Mama G-Balance.
Gestational diabetes, or GDM, is a growing threat for expectant mothers and their unborn children. GDM is a carbohydrate intolerance of variable severity with onset during pregnancy. It is brought about by exaggerated physiological changes that happen during pregnancy. In Southeast Asia, 1 in 4 pregnancies are affected by GDM. All Filipino moms, on the basis of ethnicity, are at risk of developing GDM. Unaddressed, it could lead to complications for both the mother and the fetus. For moms, they can develop preeclampsia or the development of high blood pressure and too much protein in the urine during pregnancy. They have a higher likelihood C-section, and they are more likely to develop type 2 diabetes later in life. Other health issues such as heart disease, kidney disease, and nerve damage can develop. For fetuses, there is a risk for preterm labor and delivery, altered fetal growth, breathing problems, obesity, and type 2 diabetes in life, or for severe cases, stillbirth. But there is hope. Proactive nutritional intervention early on in the pregnancy journey may help prevent the development of gestational diabetes and bring about a happy and healthy pregnancy. Because all Filipino moms are at risk of developing GDM, the brand that provides pro-mama and pro-baby nutrition now introduces the all-new Pro-Mama, the only maternal milk with no added sucrose, low fat, and also A2 protein. For 2 glasses a day, moms can complete their daily nutritional requirements. And for women at risk of GDM, introducing the all-new Pro-Mama G-Balance, a first nutritional supplement containing myo-inositol and probiotics that may help maintain normal blood glucose levels among pregnant women. A 2019 trial done in Mexico showed that supplementation from 12 to 14 weeks of gestation with myo-inositol plus probiotics reduced the incidence of GDM. There was only a 29% GDM incidence in the G-Balance group versus 48% in the control group. Proactively prevent GDM. Pro-Mama A2 and G-Balance, solutions that are pro-mama and pro-baby.
Thank you very much, doctors, for joining us this evening in this momentous occasion as our partnership with the Philippine Obstetric and Gynecological Society continues to build on an advocacy to make sure that pregnant Filipino moms are given the best nutrition that they can. This is the core of what Wyatt stands for, and so our pride and joy as we launch today Pro-Mama and Pro-Mama G-Balance, and we will make sure that we continue to build healthier generations of Filipinos together with you, our partners.